طبعا نحب نشكر الكارديو ايجيبت 2026 organizing committee for inviting us to contribute in this fantastic event. وشكرا دكتور محمد العلوي for your presentation, which really make my presentation easier. So thank you for this nice comprehensive presentation. I will have nothing to declare. My objective is to recognize HFpEF as a growing heterogeneous syndrome dominated by the obesity phenotype, describe how visceral adipose drives systemic inflammation and cardiac dysfunction, and also identify some diagnostic challenge this kind of patients, outline potential pharmacological intervention to specify specific HFpEF phenotypes, but I will leave the pharmacological intervention to the last lecture today. So as we all know that there is a rising trend of HFpEF epidemiology, high and growing prevalence. HFpEF now account for more than 50% of all heart failure cases. It reached up to 75% of heart failure patients. They have a HFpEF having high mortality. New recent registry showing that, for example, 2 years heart failure hospitalization going up to 35% and about 15% risk of mortality of this kind of patient, having, as we know, a tremendous economic burden on healthcare system. The key risk factors for HFpEF is usually the obesity, older age groups, and hypertension and diabetes type 2. As all of us know that there is an increasing prevalence of HFpEF hospitalization, even more than HFrEF patients. And the problem is most of our patients with HFpEF, they were admitted to hospitals with other diagnoses, and there is a too much delay for diagnosis of this kind of patients because of, less suspicion of the diagnosis. Because of increasing problem of obesity, diabetes, and metabolic syndrome, expecting to increase the risk of HFpEF diagnosis in the next few years as compared to HFrEF, which is because of decreased prevalence of coronary artery disease and increased therapy of these patients. So the prevalence of HFpEF will be much more than HFrEF patients. As we know that they carry, both of them, they carry a similar mortality rate. Despite similar clinical presentation, mechanistically distinct pathophysiological entity, they are completely different entities, and usually transition from HFpEF to HFrEF is very rare. We are not seeing this kind of patient. Therapy effective in HFrEF usually are failed in HFpEF patient. HFpEF heterogeneous syndrome is very heterogeneous syndrome with multiple comorbidity contributing. Mainly the central drive is obesity, hypertension, diabetes, and chronic kidney disease. As we see that the multiple dimension view of health of heart failure, HFpEF is very heterogeneous. Multiple comorbidity, diabetes, inflammation, diastolic dysfunction, neural dysfunction. Obesity has a central role, so it's very heterogeneous disease. As we know, obesity over the world is increasing for prevalence, especially in our area here in Middle East and North Africa. The range of obesity is about between 40 and 50%. In 2025, the same is more than 40% of our population. They are obese, both male and females. So obesity as a central driver for HFpEF is very important. Obesity and cardiometabolic syndrome is the most common. More than 80% of HFpEF are overweight or obese with average BMI more than 35. There is a paradigm shift that obesity is not only a passive comorbidity, but play an essential role in pathophysiology. Obesity phenotype characteristic causing left ventricular stiffness, hypertrophy, left ventricular remodeling, high resting and exercise feeling pressures, expanding plasma volume. The core concept nowadays is that HFpEF in obesity is often a manifestation of systemic inflammatory disease. They called it a meta-inflammation. A metabolic inflammation is chronic low-grade inflammation with the heart as one of the affected organ. As we know that obesity is not only mechanically affecting the heart, but also systematically through systemic inflammation could cause endothelial dysfunction and myocardial cell dysfunctions. Adipose tissue is usually, there is an excess dysfunctional adipose tissue. If we have an adipose tissue, usually that's central obesity, this will cause an chronic inflammatory inflammation and oxidative stress, insulin resistant and vascular dysfunction, and this will lead to atherosclerosis, myocardial remodeling, diastolic dysfunction, and cardiac dysfunction. If we go to the adipocyte itself, I mean, the source of inflammation, adipocyte itself is a source of activated white blood cell, source of cytokines and inflammatory markers, and also a source of free fatty acid secretion. And this all of this inflammatory mediators will cause an endothelial cell dysfunctions all over the vasculature, leading to myocardial inflammation, myocardial cell inflammation, stiffness, collagen deposition, myocardial cell fibrosis, and all of this will lead to diastolic dysfunction, myocardial cardiac stiffness, and will lead to HFpEF. If we go to the myocardial cell itself, as we know that the inflammatory markers and the activated white blood cell will invade the myocardial cells, causing myocardial fibrosis, causing increase, as we said, inflammatory markers there, and this all will cause the stiffness and the hypertrophy of myocardium, leading to HFpEF. If we go inside to the mitochondrium, there is also a problem in energy of myocardial cells. In normal heart, the energy mainly by glucose utilization, but in obesity, the free fatty acid will exceed the glucose utilization, and mainly there will be a problem in myocardial cell energy, and this also will lead to myocardial cell damage. As we see here, mostly due to the obesity and the metabolic syndrome, there is a continuous chronic inflammation which will cause all this problem, from endothelial dysfunction to myocardial dysfunction to atrial fibrillation to left atrial problem. So this cascade will go like this chronically, I mean, to cause the end result of HFpEF. Increase in inflammatory markers are more strongly associated with asymptomatic diastolic dysfunction in patients with hypertension, obesity, and metabolic syndrome compared to patients with hypertension. Thus, who having obese and having diabetes, they have a higher inflammatory marker. Serum pro-inflammatory proteins are associated with adverse clinical outcome in HFpEF. For example, TNF and interleukins, they are high in patients with HFpEF. further, circulating levels of inflammatory markers are elevated to a greater magnitude in HFpEF compared to HFrEF patients. Even in experimental mouse, I mean in obese mouse, there is an increase in marker interleukin, male interleukin 1b, interleukin 6. There is an increase in inflammatory marker in this animals who's obese with heart failure. There's an interesting article in circulation, obesity-related biomarker associated with excess intolerance and HFpEF. They studied about 500 obese patients. They found that obese patients with HFpEF, they're having higher level of inflammatory marker than patient without HFpEF. If obese patients having an increased inflammatory markers, they have a higher risk for developing a HFpEF. There is some diagnostic challenge, so we should usually suspect a high suspicion of HFpEF in obese patient with other comorbidity to diagnose this patient earlier. Treatment, as maybe we'll hear in the next slide, there is different kind of approach to this kind of patients. And for every, site of this inflammatory cascade, there is treatment for that. For example, there is trials of SGLT1 inhibitors, MRA inhibitors, SGLT receptor antagonist, and there is a new medication coming on. In summary, HFpEF is now a dominant form of heart failure driven by obesity epidemic. Obesity drives HFpEF through chronic systemic inflammation. We call this systemic meta-inflammation. Diagnosis is challenging because nitric peptides, obesity also.
Yeah.